Thank you very much. Welcome. I'm going to take this off and just have a seat here with you. Thank you for sharing your Tuesday night with me. I know it's a beautiful day outside, and so instead of a fireside chat, maybe you're just enjoying the air-conditioned theater. Um, we are going to talk today a little bit about our healthcare system and what that means really for you as individuals and for your family in accessing care in Muskoka. Let me just see if I can advance my slides here. There we go. So I've titled the talk, How to Find the Right Care in the Right Place at the Right Time. My name is Kirsten. If you meet me at work, I will be Dr. Jewell. I work in the emergency department, both in the Bracebridge Hospital as well in the Huntsville Hospital. A little bit about me. Why am I talking to you about this tonight? This is a photo of my husband and I. We are both emergency physicians. My husband also has a family practice. We both trained in family medicine, did our residency in family medicine actually out in British Columbia, and then did a fellowship year, which is just an extra year of training to do our emergency medicine fellowship. I work as a locum in family practices as well, which really means a substitute. It's like when a teacher goes on leave or is sick, I'll fill in for physicians. This morning I was in a clinic in Huntsville for a doctor that's in Greece for the week. And I covered a maternity leave for a colleague up in Berks Falls in the practice there. So I've had sort of a smattering of experiences in primary care around Muskoka over the last 9 years, but my real full-time job is in the emergency department. I've also had experience as a patient. So since I moved to Muskoka 9 years ago, I have had 3 children, all birthed in Huntsville actually at the hospital. So I have that side of the perspective. And since having children, as does happen in families, my parents have moved to Muskoka chasing the grandchildren. And so I've helped them settle and sort of navigate our healthcare system in Muskoka as well. Our healthcare system can often feel like looking at a big, sometimes intimidating, confusing building, maybe even a labyrinth, many doors. It can be hard to know what door to enter. Am I waiting for the right thing? How long will I wait? I know over the last 2 decades in medicine, I've gradually learned to navigate this world, and I'm not even an expert at it. I had to do quite a bit of reading to prepare for some aspects of this talk tonight. And so my hope is tonight you can join my kitchen table conversations I've been asked by my parents, their friends, my friends around dinner table conversations about my inside knowledge, how to access things and how things kind of work. If you have questions along the way, please wave at me. Feel free to stop and ask as we go. But also I'll leave some time for questions at the end. Also, my mother tells me I talk too fast and I talk with my hands. And so if you don't catch something, just ask me to repeat it. There's a lot of information. I just want to point you to the website. It's through the Muskoka Algonquin Healthcare. If you go right to the main page at mahc.ca, there is a little icon with this hashtag or the pound sign that's called Where to Get Care Muskoka. And if you click on that link, there's a whole page that has a lot of these links and the information of what I've been talking about. It's just compiled in a nice place there. So where do I start? A lot of people see the emergency department as their only gateway to the healthcare system. I get that a lot working in Emerge, as I didn't know where else to go or I couldn't get in. And that's okay. That's what the emergency department is there for. We're open 24 hours a day, and we are well equipped to do many things quickly, which is different than the way a lot of the healthcare system works. But there are other access points. So this is a little summary of sort of what we're going to go through today. So let's start with primary care. What does primary care mean? Primary care is really the access point to the healthcare system. I recognize this is in an ideal system and it doesn't always work this way, but ideally you and your primary care practitioner are at the center of your healthcare wheel of care. And so if you imagine it like a bicycle with spokes going out, your primary care practitioner, which can be family doctor or nurse practitioner, or often now in Ontario, we have fairly well set up teams, which may include in your family doctor's office also a nurse practitioner, nurses, dietitians, etc. This should generally be your first point of contact with the healthcare system for most problems. And one thing that people always sort of ask is, well, can't you just read it on my chart? You should know that there is no magical central chart. I wish there was. There is no central computer that houses all of your information. We're getting towards that point where more and more of our electronic medical systems are compatible and will talk to each other. But in general, you are the keeper of your healthcare records. And I think that's really important to keep in mind. Your family doctor or nurse practitioner's chart, and I apologize, I will use those terms interchangeably. In Muskoka, we have excellent nurse practitioners who play the same role as family doctors in the community, and so sometimes I slip and just say family doctor. But your primary care office will have your medical chart home that should be up to date with all your current medications, with your past medical problems. When I get a note from the hospital that you've had a surgery, it's up to me to read it and then input manually had a hip replacement on March 7th, 2014. As you can imagine, sometimes things get lost. Sometimes people change medications and it doesn't get updated. And so it's always important to have an accurate record of your own medications and your own medical problems. If you have them on a piece of paper in your wallet, that's fantastic. And this is also why your family doctor or nurse practitioner will also ask you to just bring your whole bag of medications to your appointment, just to make sure I know what you're taking and that what you're taking is what is on my chart. And it just double checks everything and keeps everyone safe. When you need a test, ideally, it goes out from your primary care to say imaging. I need to order an x-ray. And that test referral gets sent out and the results get sent back to that chart. If you're then going to a specialist, the family doctor can send the report of that imaging to the specialist. The specialist can't always see the pictures because, again, our computers don't talk to each other across Ontario yet. But ideally, things go through your family doctor. If you get referred from the emergency department, say I think you need a dermatologist after you come in for something, I might refer you to a dermatologist in Barrie, and then that report hopefully will go back to your family doctor if I've remembered to include their name, but it might just come back to me and you'll never see me again, and sometimes things can get lost that way. So again, another important reason to tell a specialist, this is my family doctor. Make sure you copy the note to them just to keep the system sort of moving smoothly. Again, hospital admissions and ER visits, notes do get sent back to a primary care or family doctor, but not always in legible format and not always very quickly. We still work on fax in the healthcare system, and when I write on the emergency chart with my very neat handwriting, the second page, so there's a carbon copy on a triplicate made, and the second page is what gets faxed to the family doctor's office, which often isn't all that legible. And so more and more of us are trying to dictate or kind of speak into a phone our reports so that they are more legible. But it's another important reason for you to understand what was happening after that hospital admission, and so that you are able to actually verbally give some of that report and that you're, again, at the center. Picture yourself at the center of that care team and taking some responsibility for knowing what's going on with your care. Primary care in Muskoka is pretty comprehensive. We have somewhere around 6,000 unattached patients in South Muskoka, and that swells to somewhere around 12,000 probably for the whole Muskoka region, which is about on average and maybe even a little bit less than average for the whole Ontario population. There are very well-organized teams in Muskoka, so the Cottage Country Family Health Team, the Algonquin Family Health Team is in Huntsville, North Muskoka Nurse Practitioner-led clinic, that's in Huntsville as well, the Berks Falls Family Health Team, and then many rural nursing stations and health hubs that are staffed by nurse practitioners. How many people here have a family doctor or nurse practitioner? And how many people do not? So there's a majority that do, a couple hands going up that don't have access to care right now. And we're getting to that. The Cottage Country Family Health Team in Bracebridge comprises of actually 3 separate clinics. So this includes the Gravenhurst Family Health Team, the Archdeacon Medical Clinic, and the Bracebridge Medical Arts Building Clinic that houses many different physicians' offices, as well as nurse practitioners blended in with those practices. And I think it's just important to know that they work together to cover a lot of For example, there's evening clinics at the Cottage Country Family Health Team where they'll cross-cover each other's practices. And if you do get seen by a physician at that evening clinic, because it's a same day or urgent appointment, it may not be your own doctor, but they do have access to your full chart, which is a real bonus if we're going to just say a regular walk-in clinic. So what are some tips and tricks? These are for those of you who have family doctors. Some tips and tricks that I've sort of come to realize that is not necessarily common knowledge. When I am working in the emergency department, I have that hat on. I often have people come and say, I just couldn't get in to my family doctor. Now, half the time they couldn't get through the phone lines because nobody picked up. That's difficult sometimes, but we recognize that often it takes phoning and phoning back and phoning back. I wish reception was, staffed to pick up the phone like when you call a private business in town, but they're just not. They're overrun. Most of these clinics, each physician or nurse practitioner will follow somewhere between 600 and 2,000 patients. And so if you can imagine a practice of 9 doctors all working in one office, those 3 front staff are fielding calls from over 12,000 patients often. So often it is just pick up the phone and call again and call early in the day to see if you can get through. Sometimes it's a little bit about talking to the receptionist or the front staff in language that is kind of similar to how the physicians or nurse practitioners have set up their practice, which means if you think you have a same-day urgent issue, like I have a rash and it's here today, and if I have an appointment in 4 weeks, it doesn't do anybody any good. I don't know what to say about a rash in 4 weeks, or I think I have a UTI. Those are really reasonable same-day appointments, and so sometimes it's about calling and not just asking for an appointment, because that might be next available. So next available appointment can often be booking 2 weeks, 4 weeks, 6 weeks out, depending on the practice. But almost every practice I've ever locumed in or worked in has same-day appointments that are kept available. It's actually one of the requirements of the family health teams is to maintain some urgent access. And so the same-day appointments often are booked for shorter 10 or 15-minute time slots, and they're single issues, so you can't bring up 3 different things and expect to have your chronic medications managed, but most practices reserve sort of 2 to 8 appointments a day for that. So that's something to know. There can also be sort of semi-urgent slots, which the doctor might need to approve to sort of fit you in. Yeah, that's a good thing to do next week. For example, a follow-up from an emergency room visit. If you have something specific to follow up, if I'd said you need your sutures out in a week, or you need to have this blood work done because I've changed a medication and you need to see your doctor in 2 weeks from now, that's an important thing to say. I've been requested to follow up in 2 weeks. They should have sent notes. Is there a semi-urgent spot available? Just a few little language things that might help. The other thing that's coming down the pipeline is some practices are now booking appointments online, and some practices have some secure messaging. There's a system called Ocean. Has anybody's practice shifted to email you with some information? So not all practices have signed on, and there's a bit of a learning curve, I think, on both sides as to how do we use email effectively and safely. There is the ability for doctors to email you, for example, hey, our flu shots are available this season, kind of a blast to everybody, or something more personal like your mammogram results came back and they're normal. We'll book follow-up in 2 years, something that doesn't need a lot of dialogue. And I think that can be a really good use. What is a bit more complicated is if there's the ability for patients to message back. In theory, that would be really nice. I think there's a lot of things that you think, I don't want to bother them with a phone call, or I don't have time to wait on the phone for 2 hours calling back. Can I just email a question? The problem we're finding with that is that it's really hard to know what can wait. And, if somebody emails and says, I have chest pain, what should I do? That becomes a really big risk to say, it's an unmonitored email. I see that 2 days later. You should have gone to the emergency department. It's chest pain. So I think there's a lot that we're figuring out with how to best use that. And it's always good to give your doctor's office's feedback about what you found useful and what you're finding frustrating or confusing. Often your actual provider doesn't know what some of the barriers through the front staff are. And so if you're having trouble communicating, or if you found you couldn't get through, or you're booking 6 weeks out, that's actually useful information for the doctors who manage their own practices to know, because that doesn't always get through. So take a little empowerment from that. My last little tip and trick is prescription renewals. We get a lot of requests for prescription renewals coming through the front staff as a message in family practice. So again, as you can imagine, if I'm looking after a practice of 1,000 patients, my inbox, that's what we call the paperwork I do that's sort of outside of paid time seeing patients. It's at the end of the day. It's the lab results that come back, the reports from specialists, and then messages that come from phone calls or the front staff. And I think on average, the inbox I was covering today when I opened it up this morning had about 50 messages, and I tried to clear them through the morning, and at the end of the day, there's probably still 30 messages left in there. So we're somewhere around 70 to 100 messages a day is what we're sort of clicking through and dealing with in paperwork. You might hear in the media as the next round of physician negotiation sort of gets out there, people talking about the paperwork burden in primary care, and that's the sort of thing. It's not just filling out forms, although that's part of it, but a lot of it is just we need to clear and kind of review every single result that comes across the desk. And so that's often what your doctors are kind of doing between patients and after hours. So prescription refills are one of the things that I think is really easily taken out of that extra work. Most physicians, most offices that are managing their practice well are going to give you enough to last until your next appointment. And so, for example, if you have a thyroid medication, I generally want to check it every 3 months if we're changing the dose, or every year if it's been stable. And so if we've changed the dose recently, I might only give you 3 months with no refills. And I want you to come back to do your TSH, your blood work, before the next one. So if you notice on the bottle, and on the bottle there's always a little spot that says how many refills are remaining. If you notice on there that there's 0 refills remaining, that should be a trigger. Oh, I need to book an appointment because my doctor wants to see me to discuss something. If you notice that you're running out and you don't have an appointment coming up, or there's been a miscommunication, you think, my doctor said to see you in a year, and now I only see, maybe they forgot to refill it. Sometimes those things happen. The best way to ask for a refill is actually not to phone the doctor's office, but to phone the pharmacy. The pharmacy can give you a limited refill. Often they'll fill 1 month's supply, and then they fax a refill request to the doctor's office that just needs sort of a yes sign off, and it goes back to the pharmacy. And that keeps your pharmacist sort of in the loop of what's happening. And that's generally been the way that we're being requested to refill things these days, is to call a pharmacy first. Are there any questions about things that you never understood about primary care offices, how things work? We'll come back to it if there are. So yeah, thank you. Absolutely. So the comment was, no, it's nice to know that there should be those urgent appointments. That wasn't always widely known. And there are some other options, like going to the pharmacy for a prescription for a UTI, which I'm actually going to touch on in a minute. But just good to remember that. Yes.
So, because we go to the office, and I would send pictures, and I had one of the ladies, my friend, using her email address, and so.
Absolutely. So the comment was during COVID, there was a big transition to virtual visits like phone visits, which in some cases has persisted. And there have been some good things from that, like being able to send pictures of wounds, for example, to know what to do with. There isn't always a great answer that is official for how to securely send photos. You know, legal liabilities becomes, you know, people don't want photos flapping around through personal emails. But I have to say, in the absence of an official system being set up, people find ways. We text, we do use a front staff email because it's the right thing to do to get care for that person. So people are finding solutions. And we'll touch a little bit on phone visits too. But first, let's speak to the people in the room who may not have a primary care practitioner. And if this isn't you, this is probably somebody you love, because again, there's 12,000 unattached patients in Muskoka. So help. What do I do when my primary care provider disappears from the middle of that circle? It becomes more difficult. Then it's just you. It's you keeping hold of your records. It's you knowing who you've seen and when, and it's you knowing, okay, is this an issue that I need to wait all day in an urgent care or a walk-in clinic for? It becomes more difficult. Ideally, our system works best, it's least expensive, and it's really the way the Canadian OHIP funded system was designed when you have a primary care provider at the center. But there are ways that we are trying to provide some aspect of care for those who don't have family doctors. So these may include, first of all, getting on a wait list. And so in Muskoka, we do have centralized wait lists. Again, the family health teams have worked together. There are 3 wait lists. There's the South Muskoka wait list, which includes the Gravenhurst Clinic, the Cottage Country Family Health teams, as well as Port Carling and Muskoka Lakes nursing hubs. There's the Algonquin Family Health Team, which includes the nurse practitioner-led clinic, because people were saying, well, should I get on one or the other? Why do I have to decide what I want? And they just got together and said, let's make a centralized waiting list. And people do move from this wait list. When there's a new doctor in town, they will often draw a large percentage of their practice from the wait list, but otherwise there is an agreement where each of the physicians try to take 1 to 2 patients a month off the wait list just to gradually chip away at it. The North is contacting the Berks Falls Family Health Team, which is just, you gotta walk in and sign the roster or phone it. They don't have a website yet. But these lists are long. The average patient has been on the list for 2 years. And we know we're recruiting heavily. We need more primary care practitioners in Muskoka. But with upcoming retirements, this list is pretty much at a stalemate. The recruits are generally, at this point, just covering physicians that are leaving. For these lists, you don't necessarily need to not have a family doctor. So you might hear there's a centralized Ontario waitlist that's called Healthcare Connect. This is often the information we'll give you at the hospital. That's a number or website to go on, and you kind of get connected to a care navigator who puts you on sort of the overall wait list, and you cannot have another family doctor, even if they're 6 hours away, to get on this list. To get on the local lists, you can have a family doctor in Windsor that you just really never get to see, and you can still get on that wait list to say, I'm gonna keep them just in case, but once I get on the wait list or get off the wait list in Bracebridge, I will let that family doctor go. And so that is an option. If you have any care, it's better than no care, but we know that local care is the best care. There are walk-in clinic options. As you know, in Bracebridge, there is the South Muskoka Medical Center and walk-in clinic. I know often these appointments fill up within the first hour. So people will say, you know, I went to the walk-in and there was a long wait, and by 10 o'clock they said, we weren't accepting any more patients, and so I came to emerge. And that's just the reality of our system sometimes. But it's a way to start. These buildings you need to go to in person to, it's not just booking an appointment, it's going to and just waiting. I was in Kingston recently visiting I went to Queens for undergrad, and I went back for a reunion. And on Saturday morning, there was a walk-in clinic right on the main street there, and it was lined up probably 50 people deep at 8 in the morning, which breaks my heart a little bit. It's just, people are so desperate for care that you're lined up at 7 in the morning on a Saturday morning, knowing that you may not even get seen. So we actually have it pretty good in Muskoka. A new initiative recently has been the Huntsville Healthcare Clinic. Has anyone heard of this one? So there is a clinic that has opened. It's local family doctors who already have full practices, but are trying to help out a little bit to fill the gaps of this unattached population. And also nurse practitioners and students. You might meet residents who actually get experience kind of manning the clinic mostly on their own under the supervision of a physician who may be there sort of part-time or maybe off-site working in their clinic, but covering the practice. So this is sort of a walk-in clinic. It takes booked appointments, so you can't just walk in, but that number is open for anyone to book. It is for people who don't have a local primary care provider. That's how they define it. And we're using it quite frequently to get follow-up from both the South Muskoka and the Huntsville emergency departments for people who don't have family doctors. It's in the building right beside the library, so it's fairly central downtown. Otherwise, options for walk-in clinics are really driving to Orillia or North Bay, which I often see people doing, sadly. So what about pharmacies? What are pharmacies able to provide for you, whether or not you have a family doctor? In January of 2023, so just over a year ago, the Ontario College of Pharmacists were given the go-ahead to prescribe medications for 13 different ailments, and they're listed here. This is a very set list of medications. So they can't prescribe everything for a UTI, but they can prescribe sort of the most common of the antibiotics. And again, pharmacists are not trained to diagnose, but if you have sort of a self-diagnosed condition, if you go in and say, I have pink eye, or I have a bladder infection, I've had them before, these are my symptoms, then they are the best people to. I mean, if I have a question, you have an allergy, you've had an uncommon reaction to something, I'll call the pharmacist and say, what would you advise? I've made the diagnosis, what do you think about treatment? So this is very much in the pharmacist's wheelhouse to help dispense these medications and give you some advice about how best to take them. The concerns that some of us have with the pharmacists prescribing is that there are certain of these conditions that I don't expect you to know what it is. Now, for example, the two I always use, acid reflux. Acid reflux might be acid reflux. It might be that you've had this for years, you take Tums for it, it goes away, you just want something that's stronger than Tums because you've had a whole bottle last month. Fair enough. But what if acid reflux is chest pain that's new? And we know, especially in women, heart attacks can present atypically. And so if this is a condition that you think it might be acid reflux, but you haven't had it before and it's uncomfortable, the pharmacist will ask you some questions. They are trained to try to pick out these kind of mimics, but they're asking them over the counter. They don't have the luxury of having a private space, of having your past medical history, of having an exam room, being able to kind of unclothe you and look at your chest. And so there needs to be some caution, and it's a bit of personal responsibility, which is not a bad thing. I think giving our general public this responsibility has been long sought after, but it just takes a little bit of double checking whether this is an appropriate use. The other thing I give the example is UTIs. UTIs always happen on a Friday afternoon and when you can't get into your family doctor's office, usually over Christmas. I've had calls from my aunt on Christmas Eve saying, can you prescribe for me? So I love that the pharmacists can prescribe antibiotics. I don't love when somebody's gone back to the pharmacy for their third and their fourth UTI in 3 months, because then maybe it's not a simple UTI. The pharmacists can't take a urine sample and send it off for a urine culture, which would grow the atypical bacteria, something that wouldn't be covered by your standard antibiotic. And so going to the pharmacy for your first one, perfect. For your second one, especially if it's within a couple months, maybe seeing your family doctor or at least going somewhere where they can take a urine sample makes sense. The other thing to think about is, especially for our young females, we don't have a sexual health clinic. We don't have a lot of women's health care unless you have a family doctor. And we know things like chlamydia, gonorrhea can present as UTI symptoms, and if they go untested, untreated, they can cause scarring and infertility for life. And so I don't want these sorts of things to get missed. The other thing is blood in the urine. If there's blood in the urine that doesn't go away with treatment, then bladder cancer is something that we need to look into. And having somebody who looks over that, and says, you've had blood in your urine every time we've done a test over the last year. Why don't we test it when you don't have a bladder infection and make sure that it's gone? That's an important. Yes.
I developed as I had been on chemo, and I really was not doing well. And my concern when I see that on what pharmacies can handle is that you can go downhill like that, and I was choking,
Mm-hmm.
and so I wound up in hospital.
Mm-hmm.
Then, and even the lady called off. So he took it to me and said, be responsible for what they feel that they're not doing well.
Absolutely. So the comment was about oral thrush. It can sometimes be really simple. You think, I got white spots in the mouth. Babies get thrush frequently, not a big deal, but thrush can be severe, especially if it becomes esophagitis. That's when it goes down your whole throat, can cause weight loss, hospitalizations. And so, like with everything, if you're not fitting that standard picture, if you're not improving, then it's always worth seeking care at a higher level of care. Good to know, though, that tick bites can be prophylaxed in pharmacies. That is another point for this summer. We do have Lyme disease in Muskoka now. When I started 9 years ago, we were saying, unless you've been traveling from the south, if you get a tick bite here, don't worry about it. We do have black-legged ticks that have Lyme that are encroaching into the Muskoka region now, especially Bracebridge. So if you have a tick and it's been attached for over 48 hours, and it's engorged when you take it off, it needs to meet all of those criteria, then you are a candidate for prophylaxis, which is just one dose of an antibiotic. And so it's great if the pharmacist can give that out. It's very low risk. Most people don't react poorly to doxycycline, and so one dose at the pharmacy is probably the simplest way. Now, if you need help getting the tick out, I will do that for you in the emergency department. It's my favorite thing to do. We do. Yeah, we do. I did my residency in British Columbia. So the question was, do we see many ticks? And in the interior of British Columbia, they are absolutely everywhere. So I saw them more there, but we do see most days on a shift in the emergency department. I have somebody who either has a tick or had a tick or thought they might have a tick. Or there's a lot of concern about ticks in the summer. So what about virtual care? Now, virtual care touches on a lot of things. It's everything from, what about a phone call with my family doctor? Can I just get a phone appointment? And then it goes all the way to these virtual care companies that have started up. So during the pandemic, there was this surge of, I think it was really meeting a need that has been there for some time, an unmet need, to give people options for how to seek care. It came along with funding, so the government typically had not been paying practitioners to see people unless they were seeing them in person. And so your doctor phoning you about results on a Friday night is just on their own time, which is fine. But once you could actually book an appointment and get paid a visit fee for it, it became a sort of reasonable model to shift the practice to. For your own doctor, for those who have family doctors that do some virtual care, the fee codes were cut substantially. I think it was by 15 or 20% in the fall of 2022. And so it was trying to encourage people to get back to seeing people in person where appropriate, because there were some practices that were not opening up as quickly as maybe they should. And it was trying to shut down the clinics that were only doing virtual care and really providing kind of substandard walk-in clinic type care. However, it did provide a challenge for some physicians that were providing necessary virtual care appointments that now were only given sort of 75% of that fee visit. There are certain things that are better seen in person, obviously, a rash, things where I just need to see, what do you look like? How are you breathing? I hate doing those visits by phone, but some things are great over the phone. And so depending on your doctor's or nurse practitioner's practice, there'll be a blended model of when can you book things in person, when can you do things on the phone. I've also been asked, what about if I'm traveling? What if I go to Florida and then I have something simple, bladder infection, and I just want to get a prescription? Can I call my doctor's office? And the tricky thing there is actually legally, so liability-wise, physicians are not allowed to prescribe for patients that are not located in Ontario. Likewise, if the physician is not located in Ontario, if I travel to BC, but I want to cover my inbox, that, messages that come in and out, I could do that while I'm on vacation. I don't need to beg a colleague to cover that for me. But if the physician is not in the province, you are not supposed to be managing medical issues, because the licensing, I'm only licensed to practice in Ontario. The license varies from province to province. The medical legal liability varies from province to province. Believe me, this is something that our medical associations are working on to try to get pan-Canadian licensing. It would make a big difference in staffing, I believe. But currently, it's a bit of a barrier. So you may hit some roadblocks there. That sort of situation, though, if you're traveling out of province, might be where these virtual care clinics come. So has anyone heard of things like Rocket Doctor or Virtual MD? There's these private companies now where it's online, you book your appointment online, and you can see a doctor. Some of them are like McDonald's, I say. You can see a doctor in 10 minutes. Perfect. Put in my order. I want a UTI medication. That's what I want. It is not always comprehensive care, I would say. They don't have access to your chart, but it does fill a need in some situations. So the visits can be, in some cases, by phone. In some, there's texting or messaging, and in some, there are video capabilities. There's usually some component of private pay to it, and so they'll say, OHIP will cover the phone visit at that whatever fee, but if you want a video visit, well, that's not a modality that's covered by the government, and so it's somewhere between a $30 and an $80 fee. There will be some companies that charge a monthly subscription. This is often used by kind of like corporations, companies that will, for their employees as part of their health package, say, hey, you get a subscription that's worth $80 a month to Virtual MD or whatever it is. PharmaSave has a relationship with Rocket Doctor, and so there's some people who have their drugs at PharmaSave and then therefore get access to booking appointments through Rocket Doctor, but you still have to pay. There are a couple websites that do have fully OHIP covered visits. They aren't as convenient. You can't see a doctor in 10 minutes. You might have to book a week out or something like that. But I think they're good to know about. And let me just pull it up because I don't remember their names. So there's one called the Central Region Virtual Urgent Care Clinic. It's staffed by an NP, and it's associated with the hospital that's in Uxbridge, but it seems to see people throughout Central Ontario, and we can kind of fudge it here. And you book the appointments online. There's another one called TIA Health, where the visits are covered by OHIP, and you get to kind of choose your doctor. You see their profiles and what they specialize in. The physicians on there can also say, I don't prescribe narcotics, or I don't see mental health, or I don't see erectile dysfunction, or I don't see hair loss, or like whatever they want to exclude, which I find very interesting. That goes against most of our Hippocratic oath or standards of care. If you're trained in it, you should be providing the service. But it's a whole new world of sort of private industry out there. I think it's something to sort of watch because it's going to just get bigger. Yes, a question. That's right. So what about a second opinion? So they can't see your imaging records. They can't see the initial consultation. I would say it's probably more useful to, for somebody who may not have a family doctor, to get a referral to a specialist. It's mostly primary care. There are some specialties on it, but I think for the most part, the use is for somebody who can't get a referral but knows you need to see a gynecologist or an orthopedic surgeon. At least it kind of gets you into the system. I don't know that it would be all that useful for a specialist second opinion. Dermatology, I would say, is an exception. I know I said I like to see those in person, but there are actually some virtual dermatologic clinics now that are doing based on pictures. Um, there's one called, I think it's called Virtual Derm. It's an Ontario-based clinic, and so for something like that, that might be worth looking into each of those platforms and seeing what they do for dermatology. Yeah. Oh, the other thing I wanted to mention here, there are a couple virtual mental health care resources where you can get OHIP covered, sometimes OHIP covered counseling, often private counseling. But if you are looking for a private counselor and cannot find one in locally, which is often our problem in Muskoka. There just aren't enough mental health workers. And if you don't connect with the first counselor that you're assigned, there's often not sort of the chance for a second opinion that way for counseling. And I find counseling is very personal. You just need to find somebody you connect with. And so if you or a loved one is looking for counseling and are able to afford private counseling as a longitudinal solution, there's a couple really good virtual options for that. All right. So some short words about some other resources that are out there. So who's heard of telehealth? So telehealth is the old name. We are now supposed to call it Health Connect Ontario. I still call it telehealth. The other word is Health 811. So they've transitioned to if you text 811 or you dial just 811 on your phone, that connects you to this service. It basically connects you with a trained, it's a nurse who picks up the phone, and they are supposed to follow an algorithm fairly strictly of asking you certain questions, and it guides you to how to access care. We joke in the emergency department that every telehealth visit ends with being told to come to the emergency department. Now, I get a biased sample because I see everyone who's in the emerge, but I do think there's a little bit of cover your butt. You know, if there's any sort of red flag words that are used, then you say, well, I don't know, I can't see you. Why don't you go to emerge and get checked out? Better safe than sorry. But there are I think there's some places and times where you just need some sort of first aid advice, or how do I access this? And this is a place to start. I was also really impressed with their website, which I had not checked out previously. So it's been revamped over the last 10 years, this whole 811 thing. And the website is really thorough in terms of talking about ways to access care. It has a symptom checker, which is powered by AI. It's called ADA. And you can type in your symptoms, and it kind of leads you down asking a bunch of questions, which I thought were good questions, and leads you to what we call a differential diagnosis. So not just one thing, but it could be this or this or this. And you can sort of read on them. There's places to click, and it takes you to valid resources where you can read more about them. I inputted a few kind of things just to test it, and I found it was fairly accurate. So just something to think about if you want to play with the symptom checker. Does anybody know about poison control? Another really good number to have on your fridge. So the Ontario Poison Centre is staffed 24/7. Number is 1-844-POISON-X, or the full number is on there. And if you ever have concerns about exposure to a chemical or an overdose, for example, real story, somebody reaching on your bedside table, took a handful of what you thought were your bedtime snacks, and oh, nope, they were your metoprolol or your bedside medication. And so if there's an overdose of medication or just an exposure, I got a splash of this chemical in my eye, what do? You hear sometimes you're supposed to drink milk, sometimes you're supposed to vomit, sometimes you're not supposed to vomit, sometimes you're supposed to have a tablespoon of honey. What am I supposed to do in those first sort of early minutes after an exposure? And this is really good, reliable information. If you come into the emergency department after an overdose, the first thing we do is the nurses take down, okay, what did you take, what time, what doses, and they call poison control. And I get a full page sheet of poison control's recommendations. And if it's something that is more complicated, I will then actually speak to a medical toxicologist to provide more information. So this is a really good resource to have. A little bit more about mental health. I talked a bit about the virtual services. We know that our mental health care is not as accessible or as thorough as we would like to see it. And probably all of us either have struggled with mental health or know somebody who has struggled with mental health and has been looking for resources in the past. The first place to direct people is usually the Canadian Mental Health Association. There's offices in each of our communities. The Bracebridge office is up there, but there's also an after-hours crisis line, which is staffed 24/7. If somebody's already a client, they'll try to direct them towards their already assigned worker, but there's if you're not a client and it's new, somebody can call and you'll get follow-up. They'll assign you a worker. They'll have somebody follow up with you by phone the next day or talk you through what needs to happen. Do you need to go to Emerge? There's also another 3-digit number called 988. It's a suicide crisis helpline. This is just new in December of 2023, so a couple months old. It's a Canadian national initiative. It's actually across the states as well, where, again, if you, as a youth, have a cell phone, you text 988. You don't want to pick up the phone and call because nobody does that anymore. You text 988 and somebody will text immediately back and engage in a text conversation. Or you can call. You're directed to a trained crisis worker who's had training in de-escalation of crisis circumstances. So this is for somebody who might be contemplating suicide or just somebody who doesn't know where to turn next. How do I access immediate help? Or how do I access immediate help for my child? I'm concerned about them. It can give resources to parents and family members as well. We know suicide is a growing problem. And it's becoming more talked about, which I think is a good thing. We know there's about 12 people a day who die from suicide across the country. And so I hope that this number 988 is publicized more widely over the coming year. All right. In our last few minutes, 911, this is where I work. What happens if you need to come to the emergency department? When you call 911, you'll be connected to dispatch, and the paramedics will be sent to your house. They can help with picking you up off the floor if you've had a fall and just can't get up. And then they can advise you, do you want to go to the emergency department? If you say yes, they can't decline. They will transport you always. But sometimes they'll say, you know, I needed to help to get up, or I just needed to be checked out. But you know what, I think I just, my oxygen's back on now and I'm feeling better. And they can kind of get you settled, take your vitals, and leave you at home. And they're trained to do that initial assessment as well. If you do come to the hospital by ambulance, I think there's a misconception that the ambulances all get seen first, which is not the case. And so when you arrive in the hospital, there's a triage system. The nurses, whether you walk in the front door or whether you come in on a stretcher, they'll take your vital signs, get a story, and then you're assigned a CTAS level, which is the Canadian Triage Acuity Service. It is from 1 to 5, with 1 being very, very acute, you're having an active seizure, you don't have a pulse, things like that, or and 5 being things that could be seen in a walk-in clinic. Many things in Emerge are CTAS 2 and 3, so sort of in between, and that's just a number that's assigned at one point in time. And so if by ambulance you come in and you couldn't get here because you'd broken your ankle and you couldn't walk, and so they transported, but your broken ankle would be generally a CTAS 4, which means you could get offloaded to a seat in the waiting room and wait along with the other people in that acuity category, which is sometimes why there's a very long wait at all times in the emergency department. Why am I waiting so long? The emergency department is a place where we're good at getting things done same day. So if you need an ultrasound, I can usually get that done today or tomorrow, but there's no booking for the emergency department. They're just, all the patients are fit in between the other outpatient ultrasounds, and so you're sort of begging and pleading spots. There's a number of places where things sort of line up and wait. And so that might be after you get seen by a nurse, you're in a bed, you get maybe some blood work started, but you're waiting to then see the doctor. In both of our emergency departments, in Huntsville and in Bracebridge, there's usually one physician on at a time. And so there's one doctor waiting to see everybody who's in the queue. There can also be a bottleneck for imaging, ultrasounds, CAT scans, things like that. And then there's a bottleneck for getting those images read. So after you have a CAT scan, there's a radiologist that is sometimes on site, sometimes in Scarborough, and they read their images virtually. And I have to wait for them to get through their lineup and give me the report so I can come discuss it with you. A couple of the tips I give for getting the most out of your emergency room visit is bring a family member if you can. Thankfully, since pandemic restrictions have lifted, we do allow a family member in the room again most of the time. And I think having a second set of ears, even writing down what's been done, what's been said, can be really useful. When you're in pain, anxious, it's not always the best time for us to be processing things. And so have somebody with you. Bring a list of your medications so that the emergency physician knows what you're already on, what you might interact with. Make sure your allergies are noted. And if you don't ask, or if you don't understand something, ask. If you don't ask, we don't know what you don't understand. And so feel free to ask questions. I know we always seem very busy, but I would rather have you ask the question now than go home, not understand, and have to come back the next day. So part of our job, I think, is explaining things, slowing down, and making sure that you understand reasons to come back if you're not getting better. Absolutely, go ahead. Yes, thank you for that. I agree. Communication is not something that we in Emerge are always very good at. I take responsibility for that. So the question or the comment was, sometimes you're in Emerge a long time because you have a blood test done, and that blood test needs to be repeated after a certain amount of time. The most common is for chest pain. So if you're coming in with chest pain, and I think the story sounds even remotely suspicious for a heart attack, I don't have a magic one to say whether it's a heart attack or not. And so my best test is doing a heart tracing and a blood test right away, and then repeating that. My standard is 6 hours after that pain that could have been a heart attack began, because it can take that much time for a protein to leak out of your heart and into your blood and down your arm to a point where we can detect it on our lab level. And so 6 hours is often the time we give. And people, from the moment you walk in the door, you're sort of committing yourself to that 6-hour repeat. And I agree, you don't always know that if somebody doesn't stop. This is my spiel I give. We take 6 hours for that protein to leak into your blood. I repeat it all over and over. But everybody has their own style of practicing, and some of us aren't great at always explaining that. It is always worth asking your nurses. Sometimes they can be our translators because they're very good. Any other questions about the emergency department? Mhm. Your pharmacy can be your best friend in terms of keeping track of your medication. So yes, if they're open, if it's during business hours, heart attacks never seem to happen during business hours for me. I work a lot of night shifts. You can always call your pharmacy, or at least tell the staff which pharmacy you go to, and we can request a list to be sent over. I'm glad that worked even across provinces. That's fantastic. Yes. The question is about something like the Cardia Mobile or other mechanisms of monitoring your vital signs, your blood pressure, your heart rate. And the answer is yes. I find it a very helpful way. We get a lot of information. I don't think we knew what to make of it, especially once the Apple Watch came out, which you can, with the newer versions, get a one lead EKG off of the Apple Watch. And it could check your oxygen saturation, which I was a bit skeptical of, but it has seemed to really be mostly accurate if you take it within the context of the bigger health picture. So these Cardia mobile devices, you put 2 fingers on, it uploads a rhythm strip of your heart rate to a device. And so people have been picking up simple rhythms like, is this atrial fibrillation or is this just sinus tachycardia? Is this a normal heart rate that goes up because I'm running, or is this an abnormal rhythm that might put me at risk of a stroke and I need a blood thinner for? That's an important differentiation. And a personal story is my brother-in-law, who's younger than I am, kept having these funny feelings. He was out golfing one day, and my husband had a Cardia device with him and threw his finger on. And with that strip, he got an ablation with the cardiologist. They didn't even wait to catch it on a Holter monitor. It was diagnostic enough for a funny rhythm that they could actually move forward with treatment. So I do think we're seeing more and more technology that's useful. A quick word about help at home. So once you leave the hospital after an admission or an emergency department visit, I get a lot of questions about, we're just not managing at home. How can we get more services at home? So home care is OHIP covered help that you can get in your home for a certain array of services. The most common would be something short term, like I can arrange nursing or IV therapy for a short period of time. This may involve going into a community care access center. So we used to call this CCAC. So you may go in for that wound care or IV, but there are services that will come into your home. Nursing checks, come to take your blood pressure, coming to help with some personal assistance. We don't have enough PSWs in Muskoka, so PSW waitlists are very long, unfortunately. But home and community care support services is what we're now calling CCAC, and anybody can make a referral to this. So this can come from your family doctor, nurse practitioner, the emergency department, your specialist, but you can also call that number, no area code, and make a self-referral for yourself or a family member, and I think that's important. You'll be connected with a care coordinator who will then sort of let you know what services you may be eligible for or what might need to be sort of private pay on top of that. I wish there was more OHIP covered services for things like bathing support or meal support, but anything that is either more like meal support or laundry is generally private pay, as is things like, if somebody is at the end stage of dementia and needs 24-hour care, often I hear, the most I can get is 2 or 4 hours of personal care, and so a lot of that will be private coverage. There are lots of private agencies out there, and I would expect sort of $30 an hour, although the cost can vary widely depending on who you're getting, as well as experience of that provider can vary widely. A wise colleague of mine, who's a family doctor, tells her patients that, and I quoted her, "You need to start making a plan for help at home, because when the time comes that you need a plan, it is too late to make a plan." And so this is the kind of thing that I think it's a good idea to start talking about early. If I ended up having a major injury and I needed help at home, even just after a hip fracture, I have stairs in my home, what would we do? What's our backup plan? Who would I call in? Do I have funding for this? Can I call family? It's really heartbreaking to see people making those decisions while really their priority is just getting through that surgery or sitting by their mother's bedside to help her get through that surgery. And so I always think being prepared and knowing what the resources out there are can only be of benefit to you. The last 3-digit number I want you to remember is 211. So 211 Ontario is a resource. Again, you can text, you can call, or you can go to the website, 211 Ontario, and it is a comprehensive resource of health and social services. And so you can see this is a screenshot from the website, and health is just one of the icons. But if you have questions about how to get funding for a certain disability, or what youth services there are. There's mental health. There's I need a social worker to help me navigate something. This is a really good place to start, and they have really done a good job of compiling a lot of resources into one place over the last 10 years since I actually last looked at this. I was really impressed with the website as well. I do have a handout out front that's just, you can cut it into sort of a wallet-sized cards that does have some of these numbers on it. If you like to have something sort of on your fridge or posted somewhere, feel free to take them for family and friends. But I wanted to first give you a little quiz. So what is the most important number you think you should have on hand if you're wondering if you have a question about your health? 911 is the most urgent number, but it should not be the first one you call. But you're right, I said important, so I'll give you that, 911. What about the first number you should call? Your doctor. If you have a family doctor or a nurse practitioner, phone your family doctor. And then in the basket of other people on the end of the line, we have 811, that's telehealth. 211, that's the social services. 988, the suicide hotline. Keep that in your back pocket, and especially for younger generations in your life who may need this at certain points in time. And then 911. So I hope this has given you a little bit of a roadmap for how to navigate some of your healthcare questions. I'm happy to continue chatting, and let me know if you have any questions.